Hi guys, this lecture is covering Chapter 5, which is joint mobilizations. So let's get started. Big thing I'm sure you guys are all aware of because we've talked about it before, but in Pennsylvania, PTAs cannot truly perform joint mobilizations. It is not part of the State Practice Act. There's two things that the State Practice Act says PTAs cannot do, and it's joint mobilizations and sharp debridement of wounds. So because we live close enough to a few other states and PTAs are able to do joint mobs in some of those states, we are going to talk about them. There may be some questions on the boards as well, so we're definitely going to go over all the fundamentals of joint mobilization so that hopefully you have a good handle on the basics. So joint mobs are passive, skilled manual therapy. So that's a big thing with joint mobs, is that these are passive techniques applied by the therapist that are sort of difficult for the patient to mimic on their own. So they're typically applied directly to the joint. They will affect some of the surrounding tissues. And the big thing with joint mobs is that we're going to vary the speed and the amplitude at which we're moving the joint. And we'll get into the grades. That's how they're graded in different speeds and amplitudes in just a few minutes. We may also use some accessory motions. We are going to talk about mobilization with movement, and I do have some videos for you guys to watch on those skills as well. We typically use joint mobs to either reduce pain, to modulate pain, or increase range of motion. So we're treating some joint dysfunction, trying to open up that joint a little bit more to allow for some more range of motion. So that could be things like pain. Pain can limit range of motion, muscle spasms, muscle guarding, joint effusion, things like that. Also, if a person has pathologies of the neuromuscular system, which is causing restrictions in range of motion, there are some joint mobs that may be able to help with that. Joint mobs are different than just stretching a joint or the tissue. Again, it's going to target the restricted capsule. So we are truly aiming to get at the level of the joint with the mobilizations. We're going to try to replicate normal joint mechanics, and we're going to minimize any type of abnormal forces that are pulling on that joint. So we do need to know the anatomy of the joints. You need to be able to think about what does that joint look like on the inside. So the surfaces, bony landmarks, convex, concave, how is that joint being fitted together? And then we also need to think about the arthrokinematics as well. I'm not going to get too far into them. Your book does go a little bit more in depth with those. So if you do want to read a bit more about roll, spin, and glide and some of the arthrokinematics, you can dig into the chapter in the book. But again, I want to just stick to the basics here and give you guys kind of a functional understanding of the joint mobs. So when we talk about mobilization, we can also use the term manipulation. And again, this is that passive, skilled therapy at varying speeds, varying intensities, applied directly to a joint. There's also a thrust manipulation, or HVT, which is high velocity thrust. This is a high velocity, short amplitude technique that's performed at an end range that is typically restricted. What you typically think of as what a chiropractor would do, those are your high velocity thrust techniques. Those are also technically a grade 5 mobilization. So like I said, we'd be going into the grades of mobs, and we will in a couple slides here, but mobs are graded 1, 2, 3, 4, which is where most of us typically stay. And then grade 5 is going to be your high velocity thrust technique. We can teach our patients self-mobilization skills. There are some sort of self-stretching techniques that can use joint traction, joint glides, joint distraction. It's not going to be quite the same as actually having a joint mob performed by the therapist, but there are some techniques to try to teach your patient that they can use at home. Like I mentioned, we are going to talk about some mobilization with movement. This is also the Mulligan treatment approach. It was developed by, I believe he's Australian therapist, Brian Mulligan, and it's using a seat belt. So some of you may have seen this in the clinic. We often use a belt to stabilize part of the joint when we're talking about mobilization with movement. Manipulation under anesthesia, we have talked about. This is a procedure that's done to restore full range of motion by breaking adhesions. So we've talked about this sometimes being needed by patients who've had things like total knee replacements, shoulder adhesions. Those are probably the two joints where you'll see that performed most commonly. And then the last one is muscle energy techniques. This is where we use active contractions of muscles to cause desired accessory motion. Where we use that a lot in therapy is at the SI joint. So I don't know if you've ever seen or talked about like pelvic asymmetries, but I will go over some of them with you guys later. So physiologic movements are movements that the patient can perform voluntarily. Accessory movements, these are at the joint or surrounding tissue, but can't necessarily be performed voluntarily. And this is where joint mobilizations come into play. So as far as the effects on motion, by applying joint mobilizations, this is going to stimulate some of the activity within the nerve or within the joint. It's going to move the synovial fluid, which helps bring nutrition to the joint. It'll help maintain the extensibility of the articular and the periarticular tissues, so the joint capsule itself, as well as some of the surrounding tissues. And it also gives the patient some proprioceptive awareness. So just with the speed that we're using to perform the mobs, the direction that we're moving, helping to regulate the patient's muscle tones. So if they have a lot of muscle guarding in the area, this should hopefully help with that as well. So indications for joint mobs, why we would do these with patients. So pain, muscle guarding, spasms, any of those would be indications, especially around a particular joint. Again, this is going to help to stimulate some of those mechanoreceptors. It's going to move the synovial fluid, help with nutrient exchange, help with healing. Again, help to hopefully calm down the situation and get the patient feeling a little bit better. If there's any joint hypomobility, positional faults or subluxations, this can help to encourage a joint to return to its usual resting position. Any type of progressive limitation that's limiting motion at the joint, or any type of functional immobility that the patient has, sustained postures or things like that that are limiting their mobility. So capsular restriction, as we have gone through the different joints, I've talked about capsular patterns. So again, if your patient is losing motion at any particular joint and you're noting that it's in that capsular pattern, then that's a pretty good indication that there is going to be some sort of capsular restriction going on at that joint, and that the person should respond well to joint mobilizations. So again, we can look at passive range of motion. If it's limited, if we are experiencing a firm end feel with that patient, again, that's usually a sign of a capsular restriction. Decreased joint play on movement, so you're actually trying to move or glide that joint and it's not moving very well. It could also be against some of the surrounding tissues, like a ligament or other soft tissue in the area that could be limiting motion. But ligaments do respond fairly well to joint mobilizations as well. Ligaments and joint capsules are both very fibrous materials, very collagen rich. They're going to respond very similarly to joint mobilizations. Contraindications for joint mobilizations are going to be if a joint is already hypermobile, we don't need to mob it any further. If they have joint effusion or active inflammation going on at the joint, malignancy or cancer in that joint, any type of other bone disease that may be detected on x-ray. Hypermobility is on there twice. So for sure, that one, if they have an active fracture, we typically do not mob joint replacements. So if they have had a joint replacement or a fusion, we're not going to mob that. We also typically do not mob patients who have rheumatoid arthritis, especially in the cervical spine, which we have mentioned before. We do want to use caution with the elderly. We might be able to get away with some of the more gentle mobs for sure. Grades 1 and 2 shouldn't be an issue. We may be even able to use some grades 3 and 4, but I would probably stay away from our high velocity thrust techniques with them. Okay, sorry. So the grades of mobilizations, like I said, mobs are graded on a scale of 1 through 5, 1, 2, 3, 4, and 5. And this diagram is directly from your book. This explains a little bit about what we're doing with the mobilizations. In the next couple of slides, it goes into explain all these things, but I'm going to talk just a little bit about them while we're looking at this picture. So grade 1 mobs are just small oscillations. So we're just moving within a very small range of motion. We are not even coming close to any tissue resistance at this point. With grade 2, we're making longer, slower motions. And we're getting a little bit closer to that level of tissue resistance. But for grades 1 and grades 2, we're still just working within the patient's available range. We're not pushing into resistance. We're not trying to increase range of motion yet. Grades 1 and 2 are used just to sort of start moving the synovial fluid, restore some normal arthrokinematics, help to decrease pain. As we get into grade 3 mobs, again, we're using these longer, slower motions, but we are pushing into some tissue resistance at this point. With a grade 4 mob, we're back to using these little short movements, and we are continuing to push into tissue resistance. So what I normally tell students and how I grade them is for grades 3 and 4, because here we are trying to increase range of motion within that joint. Push up to the level of tissue resistance, nice, slow, controlled motions into that resistance, almost up to end range each time. Then with grade 4, you kind of push to that level of tissue resistance, and then you just kind of oscillate within that area. So again, here's the explanations for those. Grade 1 are small amplitude rhythmic oscillations. So just really small, just kind of oscillating or shaking the joint a little bit, just performed right at the beginning of the range. Grade 2 are large amplitude oscillations, so longer, slower movements, again, performed within the range, not pushing up to the limit. And these two are used to help decrease pain. Grade 3 is again that large amplitude, long, slow movement performed within the range and up to the limit, maybe even a little bit past the limit. Grade 4 is small amplitude rhythmic oscillations again, so just those small oscillations at the limit of tissue resistance, trying to sort of push into that resistance a little bit to try to increase the range of motion. So again, grades 3 and 4 are used to increase range of motion. Grade 5 is the small amplitude high velocity thrust technique. It's the manipulation of a joint used to break up adhesions that are limiting range of motion. Normally we see these performed around the spine, so cervical, thoracic, or lumbar spine.